I'm John Kanellopulos, an eye surgeon based in Athens, Greece and New York City, New York. These meetings are always very exciting. There's a million of things, and I'm sure I missed already several of them. I've particularly enjoyed learning more about new devices for capsulorhexis, new devices for emulsifying the lens in cataract surgery. There's major developments in diagnostics, both in cornea, retina, and glaucoma. It's a long list of things, and I'm sure I didn't cover half of the stuff I wanted to. I think that it's a brilliant idea, and its ability, from the little that I became familiar with, its ability to give a very precise capsulorhexis using minimal energy holds a lot of promise for the surgeon that is always challenged with performing a very consistent, round, and of specific dimensions capsulorhexis. So I think they're early on in development. Once this gets in hands of surgeons and its safety and efficacy is proven, it might be a significant player in cataract surgery. It's a very good point. I think that surgeons who already are on the femto cataract wagon will probably have little interest for this, but the majority of surgeons, both in Europe and internationally, are not using femto for their cataract procedures, and this will, at least at the level that I can view it now, will offer higher safety for these procedures, considering that capsulorhexis is probably the most dangerous, quote-unquote, part of the procedure, and the rest of the procedure piggybacks on the accuracy and safety of the capsulorhexis. So I think it holds promise of becoming a very essential tool for the beginner, intermediate, and advanced cataract surgeon. I'm fascinated by the leaps that nanosecond laser technology to emulsify the lens has done the last few years. It's a technology we're familiar with from its predecessor, using this wavelength and creating plasma at the edge of a very small probe that doesn't really convert this energy into heat. We became familiar with surgeons within the European Union that use it exclusively for their cataract surgery with very efficient and safe results. So I think not only commercially labeling it as laser cataract surgery, but in essence being able to perform the tasks that phacoemulsification does with a fraction of the energy holds definite promise for much wider use, again by a very large fraction of cataract surgeons. We're very excited from the work we've done in the past to be able to now have the ability to image almost all of the cornea surface as far as with spectral domain OCT, as far as cornea thickness, epithelial mapping, as well as the ability to, with subtraction, receive and process and assess full stromal thickness maps. And then it's always fascinating to be able to evaluate glaucoma patients, diabetic patients with technologies that resemble angiography, thus making the equivalent of the angiography a very minimally invasive in-office point and shoot type of a testing. I think this holds tremendous promise in preserving vision if we can make this available to diabetic patients, which is the leading group for vision loss in the Western world for ages under 65, and even macular degeneration patients, which represent the leading reason for vision loss of patients over 65. I don't think our team is a really representative team of what what is absolutely needed. We tend to study each individual patient that we see in many different ways. I'm going to start from the most essential. Despite a good history and a good eye exam, right now the first step that carries a lot of information for me is a spectral domain OCT image of the cornea, the epithelium of the cornea, which at the same time, with some models out there, can give you keratometry of the anterior, posterior cornea, as well as thickness numbers that can translate into a more accurate IOL calculation. So in one diagnostic report, I can get the majority of the information I'm looking for. And then, of course, endothelial cell counts are always important to finish with the cornea evaluation, and then further imaging, axial length measurement. We've seen technologies that combine sine fluke imaging or topography imaging and axial length measurements. And again, we're seeing more and more the solution to the need that every ophthalmologist has to be able to assess these in the office and at the time that the exam is completed. For normal eyes, a lot of these technologies converge. It is the more difficult eyes where a cornea refractive surgery has been performed in the past that we want to know more detail and we want to correlate more than one measurement. So I think that, yes, there is confirmation of measurement sometimes with more advanced technologies, but there is sometimes disagreement or even a more in-depth imaging of the particular parameter we're looking for. And I think this adds to our armamentarium of being more accurate in IOL calculation, in preempting some of the surprises we may have encountered in the past in the operating room. And it's all about giving better visual results and higher patient safety. We have worked a lot with plasma products in lieu of very invasive anterior segment procedures that we perform. We've come through the years to use it now routinely on every single patient that undergoes the Athens protocol, in which we combine a topography-guided excimer laser normalization of the cornea and high-fluence collagen cross-linking, which we call the hurricane for the ocular surface. And but you know, being more serious, every ocular intervention does leave a significant footprint on the ocular surface. Either we call it dry eye or just a remodeling of the surface. And in a large number of these cases, plasma, platelet-rich plasma can expedite the healing process and offer great levels of comfort in these patients. We've definitely seen a much faster epithelial healing and less chances of cornea scarring in Athens protocol patients. And I think it's a great tool for severe dry eye patients. We've occasionally used it in routine PRK or LASIK cases that we felt that the dryness symptoms have gone out of hand. But I think it's a very simple, definitely a very physiological adjunct to whatever we're using currently. And in my 20 years of experience, I always respect the fact that not every medicine that we use, or I should say better, no medicine that we use is innocent of toxicity and adverse effects. So the more we turn into substances and medications or supplements in that particular example of platelet-rich plasma, you kind of take out of the table the problems with toxicity and more complications in your management. I've seen many times external disease patients improve with just discontinuing all the reasonably medications that were added along the way by several colleagues. So we always have to think that in our mind that although it's a blood product and it may scare patients and physicians alike, sometimes is the best solution you can have for short-term improvement of the symptoms of the patient. It's always interesting to make that comparison, epi-off and epi-on. I started for many years being a believer of epi-off being the only solution, having had experience with patients treated in the US and in Mexico, epi-on that had progressed on to further ectasia. So I have to admit that scared me, and in trying to almost guarantee efficacy for these patients, epi-on was for many years my sole selection in techniques. We have actually, in an attempt trying to follow the epi-on route, which of course makes a lot of sense, less epithelial injury and a quicker recovery, less chance for infection, and had proposed using a femtosecond laser pocket. Other colleagues have introduced using intracorneal ring segment pockets or channels as a mode to bring riboflavin within the cornea. But I think we're seeing, and we have definitely had significant experience recently with epi-on procedures that seem to be very effective. We've of course changed the solutions of riboflavin that we used, and we've seen many investigators do similar steps and then boost the energy used in the UV lamps and are getting reasonably good results both in traditional ectasia stabilization cross-linking and the more novel refractive collagen cross-linking, or I should say better, cornea cross-linking. I think it's a very elegant way to expedite the half hour or hour that sometimes epi-on use of riboflavin needs to reach that point where the procedure will start. I think it's a very valid option along with using riboflavin solutions of higher concentration, riboflavin solutions that are claim or are able to break the epithelial consistency and allow the large molecule of riboflavin to enter into the anterior stroma we're most interested in. I know several clinicians use it exclusively. We use it occasionally, but I think it's proven to be a valid option. I always enjoy in meetings like this familiarizing myself with newer excimer laser technology, guidance systems. It has always been part of our clinical practice and a personal investigative interest of my own. And this is probably the premier meeting to see all the technologies excelling in Europe. And I particularly enjoy that part. There's many laser manufacturers that have brought great innovation. I've definitely enjoyed the work on the SMILE procedure over the last few years, and with my short, brief clinical experience and laboratory experience with it, I can already, without trying to preempt it, see that it definitely will hold a significant place in laser cornea refractive surgery. This is what these meetings are most beneficial for us about. We always learn more. We discuss with all different companies and hopefully become better clinicians ourselves. We hear a lot of whispers, nothing officially yet, that, and we understand that the industry is pushing for lasers that will be able to carve, and excuse the very gross term, the cornea in a more accurate way. So we're looking for that precise femto or ultraviolet laser scalpel that can bring down that standard deviation of femtos from maybe 5 microns to a micron or even less. And I think that there's a lot of work. We had hoped that nanosecond laser would be able to do that in the past. I think that pathway has been abandoned for now. And we hear a lot about UV being the next frontier and a lot of promising R&D work from several companies. So we're very much hoping that this will come to fruition, and we will soon have a generation of lasers that will be even more accurate than the femtosecond laser. It always surprises me saying that when we were so much, and I am currently impressed with things we can do with femtosecond laser, both in refractive surgery but also in advanced cornea surgery techniques. As a cornea surgeon for almost 20 years now, I think the precision of being able to do work within the cornea, for instance, the SMILE procedure on its own is a real surgical marvel. For any cornea surgeon that has trained in my generation to incise the cornea with a manual trephine, to reach the level where you can design, follow a nomogram, and carve basically a lens of the absolute customization that you can is quite remarkable. And all the other indications that flow from this initial, I think, great landmark. We felt the same way when femtos were able to create flaps. I think it really changed my personal LASIK practice, and it changed LASIK globally. And its cornea surgery applications are endless. So I think that I'm always impressed every day that I go into the OR and use a femtosecond laser, of the ability, the precision, and the very little interaction it has with the rest of the eye. I think it really is a major accomplishment for eye surgery.